Morning, everybody. Dr. Mikhail Schneider is the founder and chief executive officer of Nightingale Education Group, a mission-driven organization focused on innovative healthcare workforce development across the entire professional continua, from certificate programs to graduate studies to reskilling and upskilling through continuing education. From 2012 until 2023, Schneider served as the first president of Nightingale College, a higher learning institution dedicated to closing education equity gaps and creating geographic, socioeconomic, and demographic access to the nursing profession, creating thousands of new nurses throughout the United States. A visionary leader and a registered nurse for almost 30 years, Schneider has a wealth of management experience in post-secondary education for health professions and healthcare delivery services. He is a published academic author, conference speaker, and guest lecturer, specializing in strategic planning, organization development, forecasting, and management. Schneider holds a Master of Business Administration degree from the University of California at Berkeley's Haas School of Business. In 2024, he was awarded an honorary doctorate in nurse education leadership and innovation. Dr. Mikhail Schneider.
Thank you. Wow, that's long. That's a long intro, everybody, huh? All right. The most important thing in that intro is what? I've been a nurse for a very, very long time. Actually, I've been a nurse for 35 years this year, and RN in the United States for 30 of those. So a very, very exciting year for me. 35, 30, all sorts of anniversaries. And so thank you all for coming here. Hello, you people out in the cyberspace. It's good to be with you. I can't see you, but I feel your presence. So for those of you in the cyberspace, you'll interact as well. There's a chat happening that, pay attention, put some things into the chat. Somebody in the back here is monitoring the chat. Mary is monitoring the chat for us. She'll pause me every once in a while, and then, if you have questions or any kind of contributions, she'll read them out, usually the chat with, how many people we have out in the cyberspace? 787. The chat goes very, very quickly with 787 people, so you lucky you can be heard every single time here in the room. So, but for those of you, again, engaged in the chat, pay attention that throughout, Mary will pin a question up on top of the chat, and then you gotta click on the link there, right? Is that how it works? Yes. Okay, you click on a link, and then you go to something else opens up, and then you answer the question. Yay, that's how we keep attendance monitoring for you guys. See, you're off the hook for all of it. See, it's good to show up, right? being 3D. By the way, y'all, we're coming to you from the lovely state of California, and Universal City is right around the corner. And I had the fun, some of us had a fun day here on Tuesday going to Universal. I've never been. Feels like I've been, because I'm like, oh, I've seen that. Yeah, maybe I have. So I was like having this dissonance, confusion. Have I been here? Have I not? No. Now I have. That I know for sure. So thank you all for coming again, braving the traffic and all of this. Now, the reason I said that this particular part of my bio is the most important part, because that's what has driven me my entire career, being a nurse, right? And what, obviously, welcome to LVNs, yay, good for you for continuing and pushing toward the RN and the bachelor's, but hi ladies, how are you? Are these still taken? No? Okay. Oh, somebody's coming. Yay, come on in. So yeah, and for the rest of you, I commend you on your decision to become a nurse. We certainly need nurses. We'll look at a lot of data today and explore the reasons why we need nurses. And then also the bottom line of today is that the future and anything in the system is not going to change unless you decide to change it and do something about it. We're very good, it's a human thing, right? We're very good at wishing and dreaming and praying and all of this waiting for somebody else to come and make it better for us. Newsflash, nobody will. So with all the dreaming, continue wishing, continue, kind of exercising the mental muscle around this, but you also have to do. You have to do things to change things, and things need changing in order to move us into a better place as a nation, as communities, and so forth. And so today it's all about that. It's you engaging with me on kind of looking at the data that we're going to be seeing, and then brainstorming, right? And telling me, I can do this. Now, the question is also not what you're going to do in the future, because the future is, but what you're going to do today. Starting today, because you can, right? Not powerless. You already can, especially if you're a VM, yay. So yeah, why am I like highlighting this nurse? I'm a nurse. What's the promise of nursing? The fundamental promise of our profession. What do we promise to the rest of, population in this country? Come on. This is where the interaction begins. Yes. The compassionate care. Right. Okay, so we promise compassionate care. Why? Why both compassion and care are so important in what we do, and what becomes as a result of that, as a result of the promise. What's at the end? It's not a leprechaun, with the, pot of gold. No, that's not what's at the end of our rainbow, right? If we do our jobs well, and if we engage in this system well, what is the promise of it? What can this profession deliver? Yes? Decreasing medical errors, for sure. Yes, that's one of those things, and it's a portion of it. But the big thing, okay, we're getting closer. Patient outcomes. What other outcomes? Healing. Health. At the end of the rainbow of this profession is health of the population. So it's not only about taking care of those who, infirm and sick, but also managing wellness and managing all of the other things that are necessary in order for population health to become better. So yeah, this is what we're going to talk about. Current issues, future solutions, all in the search on our pathway to bringing this nation. I wish I could do it for the world. I can't yet. Not all powerful. But this nation and your community, the community that you're a part of, where you live, the people that you surrounded by, bringing health to them, facilitating their journey of both healing and wellness and everything else in between. So we'll start with this, health, and then I'll throw a word equity in there. We'll talk about that. Somehow the word is frowned upon nowadays. It shouldn't be, but we'll explore that together. So let's start with health. And those of you in the cyber chat thing, the first question, why is health?
Pinned questions aren't working right now. We're trying to figure out why the pinned isn't working.
Okay.
But we will just drop the questions multiple times.
Okay, the question has been dropped multiple times, people. Worry not if you don't catch it. Stop the chat. Stop the chat.
We're working on getting that pinning up right now, so it should be running up here pretty soon.
Why is health important? You guys, why is health important? Come on. Yes. Overall, right. It's a fundamental foundation for individual thriving, right? You can't be enjoying your life to the extent that you could, and depending on which point in your life you are, right? Your kids, your grandkids, whatever else, right? Unless you're healthy. So happiness fundamentally is rooted in being healthy, right? So that's on an individual level, yes, that is very important. What else? Why is health important? Yes? You live longer, right? So again, this is individually, you know, if you're happy and you live a long, fulfilling life, wow, isn't that what we're all, at the end of the day, are after? Nobody's like, meh, no, gotta go. 23, I've done it all. Right? No. Everybody, we're in pursuit of that long life and happy life on an individual level. What else? Why is health important? If individuals are healthy, then what? Yeah, the community becomes healthier. And what does that mean? And what does it lead to if a community is healthier?
Overall prosperity.
Ah, here we go. We're getting to it. It is a fundamental element of overall thriving and overall prosperity and overall economic activity and all of that makes us thrive and grow and develop and push for better things. So healthier workforce is a more effective workforce, right? Showing up at work, if everybody feels well and everybody is happy and brings joy to their workplace because they're healthy, imagine the outcomes of that, whatever they do, and how that changes, and how much more they can give and produce. So all of this, many studies, this has been around, this knowledge, for a very long time. Back in the 1990s, Western Europe, Germany specifically, they have done study after study after study that correlated individual health and population health to their economic prosperity. The healthier the population became, the more prosperous the country became. And so that's a very, very important thing, and that's what we're after. Okay, so now switching gears, though, I'd like to ask you about equity. And what is that? What is health equity? Or equity just of any kind? Equity, what does it mean? Yes? Equal access, part of it, right? Equal access is maybe a part of it. So let's start with equality, because that word is a little bit easier to comprehend. Equality, what does that mean? Yes. Equal, right, I know, but like what yes?
It means that people have different, equal access to health.
Correct, equal access, so everybody gets the same. That's equality. Everybody gets the same thing. You get it, I get it. You know, it's like Oprah, you get bread, and like I get bread, cars, whatever, right? That's like equality in her audience. For those of you who are too young to remember Oprah, she was this big TV star. Still around, still doing magical things. Anyway, but yeah, it's everybody gets the same. That's equality. What is equity? Yes? Fairness, true. How? What does it mean? What does the word mean? To be equitable. To be fair to each person, and that fairness really is in that person. When we talk about health equity, every single individual doesn't get what everybody gets. They get what they need, and they have access to what they need to achieve the same or similar outcome to somebody else, to everybody else, to another group. So this community and that community, their outcomes are similar. But what they need to achieve those outcomes, because of all of different dynamics in their communities and their lives, in their past, historical, cultural, all of this. The need is different. What they need in order to get there is different. And when everyone gets what they need, that's when equity ensues. So this is an important distinction to remember. I'll show you this. This is from the 2020-2030 National Academies of Medicine report on the future of nursing. A very interesting document. It's long. This is a very quick summary of it. So I'll recommend at a certain point, read it up, right? You don't need to read it all at the same time. Find it, read it. It's called 2020-2030 Future of Nursing Report. It was published in 2021. It was meant to have been published in 2020. Why was it published in 2021? Why wasn't it published in 2020? COVID, okay. All right, so everybody still remembers, right? Okay, good. Phew. Because there's going to be some blips in the data, and those blips in the data are really driven by the fact that for, like a year, we're locked down and then couldn't go anywhere and nothing was happening and all of that. However, so I'll read it for you because this is important. This is the conclusion of the report. And this is specifically targeted to the nursing profession, right? The future of nursing. So we have to unleash the power that this profession holds, unleash it. It's not unleashed today. In order to, so we will never thrive as a country unless we all have access to what we need to have a healthy life, no matter who we are or where we live. Everybody's with me so far? Should we exclude anybody? I mean, what if they're a really, really bad person? Very good, right? It is not ours sort of to say, okay, well, only a few are deserving of this. We've done this for a very, very long time. Everybody is deserving of it. If you're a human being, you're deserving of it. Now, which brings me to this little tidbit for you. If somewhere deep down in, your heart, soul, whatever, you're like, yeah, for everybody but that particular type of person. I will care for everybody but that one. Profession is not for you. Truly is not. So, get out while you can, because you will be miserable and you'll be delivering miserable care to people. If you're gonna start deciding how to dole out your compassion and your care based on what they look like, what they sound like, where they come from, what they've done. Everybody with me? All right. Everybody still wants to stay? Or should we people are dropping off and it's like, oh no, oh, poof, didn't realize that one. All right, just kidding, yeah. But, okay. So then the next thing says, nurses are catalysts for this change. They're trusted bridge builders who collaborate with people, communities, and organizations to promote good health and well-being no matter one's background. We're all together, yes. Good health, well-being, nurses promote it. So all of you all that are like, my destination is like the tippy top of acute care. That's when the sickos come, and I'm going to be dripping the stuff in their veins, and ta-da, very glamorous. And then McDreamy will come around, and that's the old show called Grey's Anatomy. For those of you who are not, I blame TV for everything, for not showing us actually what. I hear The Pit is good, but I haven't really gotten into it. Anyway, so promote health and well-being. Part of what, and this is off the bat, I want you to carry this out. Some of you may spend your career working in ICU, or as 60% of everybody who comes, oh, NICU babies, sick babies. Very, very tough job, by the way, the sick babies. But no, that's the vast majority of you all, and out there in your communities where you really are needed, is health promotion, prevention of diseases, and effective management of chronic conditions. And we'll talk about a little bit about that later. But that's 2. And then 3, the punchline of this. For our country to advance health equity for all, the systems that educate, with me, educate, pay, employ, and enable nurses need to permanently remove practice barriers, remove the barriers that exist today throughout everything. We can touch upon education a little bit. You know, the reason you're here today at Nightingale is because the systems here in the state of California are notorious for creating barriers to diversifying the profession, to increasing the numbers of the profession, and I can talk a lot about that. That's the whole other topic, but continue thinking about it. All of those barriers have to be permanently removed. The entire system must value the contribution of nurses, prepare them to understand and tackle the social factors that affect health, and diversify the workforce. We will never achieve health equity for all until all of those things are true. And very few of those things are true today. The National Academies of Medicine, formerly known as the Institute of Medicine, has published the first report like this back in 2010. Actually, 2009, and it was 2010-2020 report. The first one was back, help me count. How many years have passed since 2009? 17. We have not really made a dent in moving toward health equity. So think about it. We're going to talk about it. But let's look at this. Let's look at the profession. How many nurses, how many RNs? Let me ask you this. How many RNs are there in the United States? Actively licensed registered nurses. Anybody has that tidbit? Come on. Well, take a wild guess. Come on. Throw something out. We got to start somewhere. Millions. Millions is correct. How many? How many million? Ooh. It's somewhere between 2.6 and 10. So not either. Right. So there's 4.3 million actively licensed registered nurses in the United States. Now, about 3.8 million of whom actively practice in the profession in some capacity. So they use their license. 3.8, all right? What is the population of the United States? Ooh. The what? Yeah, so it's you know, depending, like if we counted everybody, it's likely a little higher, but so the point is, actively practicing nurses account for at least one, and this is just RNs, 1% of the US population, meaning for every 100 people, there is an RN. Now, I betcha you have more friends than that on your Facebook thingy or whatever the popular thing now. More than 100, right? Yeah. Imagine if, as nurses, we actually honed our power and we used it. And we didn't just come in, clocked out, but we did everything that is in our power to change because we are powerful. If we actually started thinking and framing everything from the equity standpoint, wow, we would change the world. We're not. We're complacent. We're not showing up. We're not in the rooms where it happens. Those of you Hamilton fans, perhaps, recognize the be in the back. She's like, yeah. Well, I want to be in a room where it happens. And so should you. Be there, change it. It is we'll talk about what you need to do prior to I'm changing the world. But you hold that promise and you hold that power. You hold the power, the promise of the profession in your hands, and you hold the power to do something about it, to move you toward that promise. Cool? Everybody still with me? Fantastic. Now let's look at this. That FON report calls for diversification of the profession. This is US racial composition. 41.1% of the entire US population identify as either non-white or Hispanic. Look at the RN composition, profession of nursing. It is 80% white, most of whom are female. I'm all like, yay! We need everybody in it. But we gotta start rebalancing it a bit and adding other people into it in order for communities to do better. We'll explore why a little bit later and how this really is affecting the outcomes of our healthcare system. So it's called for diversification. It's called for diversification in 2010, and we've been like, wishing, praying, doing whatever it is that, except removing barriers. Yeah, doing everything else, with the hope. We're hopeful people. Sometimes we gotta, add action to hope. So hopefully you will. Another tidbit of information. About 1 million nurses will retire, and this study was done in 2023, so 3 years ago. By 2030, that study said, 1 million nurses will retire out of the workforce. So we are becoming, and we're not replacing that number nearly as quickly. So the profession is on track to remain short for a very, very long time until something changes, until the systems that educate and all of that other stuff change, remove the barriers. You must work on removing those barriers. I cannot do it all alone. I wish I was, Oprah. But this is the result of nursing education today. A very fresh study that says 50% of all new nurses, new licensees, leave their first job within the first 2 years. Leave trying to find something better, something whatever, because the job is tough and they're not prepared. They pass exams on the first attempt. Whoop-whoop, whoop-de-doo. But working in the healthcare is very different than, taking a test. So that 33% of all new licensees in the United States leave the profession within the first 2 years. A third, after all of the time, all of the money, all of the energy, everything that they've put into it, to getting to that licensure, I don't know where they go. Real estate, probably. Who knows? Let's make sure that you do not become a part of either of those statistics. Who's responsible for you not becoming a part of either of these statistics? Who? Ourselves. Yeah, me. Just say me. Not Mikhail. I'm not responsible. We can offer you resources, show you the way, facilitate your journey, all of that. But you're responsible ultimately. You're responsible for what you know. You're responsible for how you show up. Not me. Okay, and now for the, it's not a riveting conclusion yet. This is just the beginning. We're going to compare, and for those of you who've seen these data points, good for you. It's going to be, not new. For some of you, it may be. And so we're going to jump in and explore how we're doing compared to other countries. Now, what I've compiled here, there's 2 studies, one that came out in 2024 and one that came out literally 10 days ago. Both are published by Commonwealth Fund. It's a non-governmental, non-partisan think tank research organization that researches healthcare systems, everything across the globe. They're based here in the United States, and they do a lot of research, obviously, on the US healthcare system, and every once in a while they publish these comparison studies of how we're doing compared to others. And so all along, the first study was published, back around, I don't remember exactly the year, but that 2009 mark, and they've been, every couple of years, they've been refreshing it. All along till 2024, they were only comparing the US to other high-income countries. So the likes of Australia and Canada and Germany and Switzerland and countries like that, because we are in that pack. We're a high-income country. This time around, they did something more. They've expanded the comparison sample to include some middle-income countries, like Turkey, like Chile, like Mexico. The results haven't changed much. We're still underperforming compared to vast majority of them in pretty much everything, despite the fact that we spend the most. So this is the 2024 study. This is everybody. That's us. See, it even says us. Comparative. This is how much we spend. That's everybody spending as a percent of their entire economy, gross domestic product, and that's us. And that continually increases. We spent nearly 1/5 of our economy on healthcare. And look, if we were getting great outcomes, by the way, the slides will be shared with you later in a PDF format, so like you can, don't need to constantly do that. But if we were getting amazing health outcomes and amazing equity, amazing equity outcomes for that spend, I'd say, okay, fine, let's spend it. But we're not. And that is really very sad. So how much do you think we spend per head? 18% of the economy for everybody who's counted. Let's just for everybody who's counting in our economy. How much do we spend on healthcare every year? Anybody? Wild guess? Yeah. It's somewhere. The number is somewhere there, right? So it is. This data. It's right under $13,000 per capita. Per every person, whether they're engaged in healthcare or not. So we counted how much we spent, we counted everybody who we count, and then we divided it, and we came up with that number. So, see everybody else? Yeah, oh yeah. This is comparison because this will be important. This is Mexico. That's us. Mexico spends this much per person, a little over $1,200. We spend almost $13,000, 10 times as much. And our outcomes are not that different. Yep. And then everybody in between. Again, the middle-income countries, Turkey, Chile, Israel, Spain, Korea, and then you have the high-income countries there. This is how much we total spending and household out of pocket. So in the United States, the total is that much. The out of pocket is this much. We'll address that also because that seems like, oh, well, maybe we're not the worst in like out of pocket spending. Just you wait. I'll show you. I'll show you how this is not, a bit misleading. So, and then pharmaceuticals and other non-durable medical goods, Yeah, why are we spending so much on pharmaceuticals? Perhaps we're the only country out of anybody who advertises pharmaceuticals. Ask your doctor, and perhaps you will twirl in the hills just like she does. Right? I mean, it will bring you happiness. If only you ask your doctor. Yes. Speak up, speak up. Right, exactly. Other ways of coming into health and into wellness and perhaps preventing a lot of stuff from happening in the first place, but also they go the longer route, but a more sustainable route in getting to health. What do we want constantly? I want it now. I'll sue you if you don't give it to me. Immediately. Fix me. Yeah. So our behavior as a population, right, contributes to the fact that we way overspend on pharmaceuticals. This is and the line, every line that you see that goes right across, that's the average of all countries, like on all of these slides. So, this is per capita, and the total. Again, we're an outlier. I mean, I know, like, it's funny, but it's not. It's like everybody else. We spend the most, and we get the least for it. Spend the most, get the least. So, sad. It is sad. Part of the reason that this happens, I mean, there are very many reasons for why this happens, but again, we, as a profession, have not exercised our power. I mean, we show up, we do well by a patient, but that's where it ends. And doing that like one-to-one and thinking that the system will change, no, it won't. This is the equity of healthcare access and experience among high-income countries. We are most inequitable in access. This is part of the reason why we face the most barriers to affording care. It is expensive, and we are forced to spend a lot of our income on it if we want access to it. Here's another one. We're at the very, very end, and what this says is that 50% of the US population, low-income population, reports problems accessing care due to cost. 27% of high-income people report problems accessing care because of cost. That 27 number in New Zealand, that's the low-income count. So, wow. Are you outraged yet? I'm beginning to be. Okay, so skipping needed care because of cost, skipping prescribed medicines, that in that orange, skipping the medical test treatments and follow-up, that's that green line, skipping consultation in the first place, that's the dark line on the, and this is the percent of, again, the percent of population. And this includes some, a larger example of countries. Let's talk about that one. So all the spending, and then, who said long life? Chances are Not going to be as long as you lived somewhere else. The data constantly shows that, right? We're at least 3 years lower than the average. And this includes everybody. That line that is lower than us, that's Mexico. Everybody else is higher. But again, we spend 10 times as much and still don't get the outcome. So how does it feel to know that statistically you will die sooner? Not great, huh? All right. Doesn't feel great for anybody, for the rest of our population either. So what are you going to do about it? That's the question. Move. Okay, so I'm creating a mass exodus of nurses from the United States. I'm moving. That could be a solution, but I think a better solution would be I'm gonna do something about it here and make sure we bend the trend line, right? And we start go. How? Oh, right. Yes. But how? Like any ideas? Any ideas so far, right? We'll dig into some other stuff so it'll become clearer of what can be done. But what can you do? Individually. Educate, yes. The what? Advocacy is great. Not the first steps.
What can we do in order to
prolong life expectancy. Yes. Unbiased care, I love that. Where do you start, though? Yeah, yourself. Oh, wow. If a thing that I want you to carry out of it, one of this, it does depend on you individually. In any of it, in all of it. You have to start with you, then you can advocate better. Right? Then you can educate better somebody. You can navigate and facilitate somebody better through their journey. Not sort of, oh, don't do what I do. I'm smoking bad. Vaping bad. But don't do it. Don't look at me. Mommy bad. We constantly do that. We don't model it. We provide lip service to somebody. And we show up, and they look at us, and they're like, well, they must know better. They have gone to school, so this all must be noise, that I shouldn't be doing it, because look at them. I can smell it, great. It's like, I can't wait to get out of here with my tank. And go around and do it. It starts with you, and then all of those other things have to, in order to educate, though, what do you have to do first? Study, learn, yay. It's not just gonna happen miraculously. I wish I was Oprah and you get all the knowledge and you get it and it's right in your head. It's like transfer, an immediate transfer. I wish I came up with that, right? I'd be happening. if I invented that thing. From me to you, woo, all of it, Just walk through the door, magic dust, magic dust, magic dust. And then you come out, right, 5 minutes later, yeah, I'm it. I can go and do it. If you don't know your stuff, it's not going to happen. You're not going to convince anybody about anything, changing the system or changing their behavior or anything like that. You must learn. You know that minimum grade that you have here? I don't know what it is. 72.5, yay! Imagine your nurse showing up and got a 72.5 on this one. Barely scraped by. Didn't have time. Or whatever else. and yet tick tock, tick tock, tick. Whatever you do with your time, I don't know. I mean, a lot of this, I reckon, yeah. So yeah, no. 72 and a half, yeah, okay, it may get you past school. But it, like, will you be a really awesome, like, if you don't know some stuff? Probably not. And we just, in school, is just, you know, fundamentals of all of it, of reasoning and all of that, and then you use that then to hone it and hone it and hone it and become better at advocacy and become better at unbiased care and become better at educating those who you work with. So this should not either be or feel like a walk in the park, and it won't. You will cry. Oh, you did already. Okay, all right. So well on your way to becoming a great nurse. But the one thing that I know, you're showing up, you're doing it, you're pushing through. I know this one thing about the vast majority of everybody who enrolls with us. You're resilient. You are resilient. And you can do it. Use that resiliency that you have in your life. For whatever else you use it. Use it in this as well. It'll serve you well. And it'll serve your patients well. And it'll serve your communities well. So think about that. This can change. It's not going to change overnight, but it can. Let's look at another one. Avoidable deaths. Again, the only country with higher level of avoidable deaths is Mexico. That's it. Everybody else kind of packed there, so we're not, you know, again, compared to everybody else, we're not doing as great. This is potential years of life lost at age 75, a lot, so same longevity. Reductions. So see, this is everybody, that's us. From 2009 to 2019. Reduction, 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 reduction. Ours is like, reduction. Again, funny but not. Part of what I would like you to carry out of this with you today is a passion, an outrage about all of this, and a passion to change it. You with me? She's like, I'll be doing it. I'll be changing it. Yes, my community is gonna go and do better because of me. If you put that in front of you as because what I do, things are going to change in my community, wow, that would be awesome. And then you learn, and then you use your power and all of that stuff in order to be able to change this. Wishing, praying, waiting for the government to do it is not going to happen. We've been waiting for somebody else to come and do government or whatever for a very, 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 ever. Has it changed? Well, it certainly is better than, yeah, I mean, we're doing probably better than, the early in the century, last century, right? Kind of 1950s, a little, we know, most of us know not to constantly just because, Madison Avenue told us to. It was sexy, right? Mad Men, anybody? Seen that one? Like smoking was the coolest. Yes, not any longer. Anyway, this is outrageous. This is maternal mortality. Deaths. This is US overall. This is US white. This is US black. Black women die as a complication of pregnancy or childbirth. And the year following that, in an outrageous numbers. We're doing worse than vast majority of developed and some underdeveloped countries in the world. Why? Cost, yes. Bias, why? Serena Williams has a good story to tell about this. She almost died delivering her last child. It wasn't her first. She kept saying, something is not right. She's like, I'm an athlete, I know my body. Something is not right. Something is happening to me. Nobody would listen until she pulled her like celebrity power card and like made them. And yeah, and by the time they got it, the intervention, started interventions, it was almost too late. She's fine, her baby's fine, but anybody else in that situation would not be fine. So, sad. That one of the highest rates of suicide. US rural areas are kind of that green bar next to, and the only higher one is Korea. I'm not sure what's happening there, but you know, there's reasons. South Korea. North Korea, we don't, yeah. They don't share anything with anybody. We don't know much. So, you know, would not be a good comparison to us either. I mean, so, okay. That's that. Adults with multiple chronic conditions, 29% of the US population has multiple chronic conditions. 40%, at least one. 40% of the US population has at least one chronic condition. And most of those chronic conditions are not congenital. They're not genetic. They're self-inflicted and system-inflicted. Care to tell me, like big ones? Type 2 diabetes. Well, asthma is environmental, yes, absolutely. Environmental cancer, hypertension, obesity, yes. Yeah. Multiple chronic conditions. Speaking of obesity, 40%. Now this number is from 2020. So with the advance of GLP-1s, this number, so the new data that will come out, this number is going down. But, you know, I mean, the miracle GLP-1s, but yeah, this is pre-GLP-1 rate. I have a little bit of a newer thing. I'll tell you in what it is in California. Oh, great. We're very secure at Nightingale. There's like, you probably have noticed. Anyway, I'll find it at the break. I'll tell you what it is in California. We produce new physicians at one of the lowest rates. We have the fewest primary care providers. That includes NPs. Those of you who are like, you know, maybe it's not NICU. Primary practice needs you, so think about that. Very low supply of that. But, you know, the one thing we do all right is the care delivery. When somebody accessed it, then we're okay in delivering it. It's the getting to that point is what ails us. So yeah, just to summarize and give you some numbers, and there's a couple of questions that will be pinned, as in how much United States spent on healthcare in 2020. That should be from 2023, that line. So 5.3 trillion on healthcare. We are, winning across multiple categories: mortality amenable to medical care, infant mortality, life expectancy, suicide rate, obesity rate, prevalence of chronic conditions, cost-related healthcare access problems, healthcare system efficiency, and healthcare equity. Winning! Doing so good, huh? And yeah, we're spending the most, both. So the number on the other chart, almost 13,000, that's a bit outdated. The latest from Centers for Medicare and Medicaid Services put the spending at $15,474 per capita in 2024. $15,000. What could you do with $15,000? A couple of things, right? Too bad it's all going in there. We have a 7.9% of our population uninsured. It will increase by 2023 to almost 31 million of people in America will not be insured. We looked at the 18% of gross domestic product, and our healthcare spending outpaces economic growth constantly, year after year after year. The economy grows. Like all those numbers that you get, like, ooh, economy grew by so much. And like if the number is really, really low, everything tanks, and it's like, everybody's sour. And then, oh, economy grew really, really well. Oh, then everybody's happy. Yeah? Okay. If it would be a good thing, we would be always happy because healthcare spending grows all the time and like way more than anything else. All of the milk that we produce and the eggs and the cars and the whatever else this economy has doesn't inflate as much as healthcare. Inflation number, bad, right? Yeah, okay, so that's a big contributor. Nobody you don't see, right? You see the economic reports and they're like, electricity went up, steak went up. Nobody ever is like, and guess what went up the most? Your health care. Yeah. So, all right. With that, actually, I'm going to show you another couple of things. Yeah, because we have a few more minutes. So, digging more into the outcomes. This is a map of the biggest difference in our healthcare system and everybody else. Tell me more. What does this mean? What do they have that we don't? What does that mean? Everybody has access. Everybody has access. Those are the countries that have achieved. And what are the two countries on the map that haven't? Us and Mexico. Does it tell you anything? As we've seen our outcomes and Mexican outcomes. Can you draw any conclusions from the fact that the worst performing countries by the way, OECD is the Organization for Economic Cooperation and Development. So that, and they have tons of data, and so you can go like global data. What does this tell you? Should we not have that conversation? Just because your TV station told you not to? Talk about it? Turn off that thing. Turn off your TV. Remove all of the pundit hats that you carry. Stop parroting what they tell you on TV. And repeating it and repeating it and repeating it. Universal coverage, bad. Universal access, bad. It's going to destroy everything. Or it's the only panacea. That is not correct either. Turn off TV. Yes? What universal coverage means? It means that every single person in a nation has access to care. The access is prioritized. It doesn't mean that the government pays. So universal coverage doesn't mean that it is all owned by the state. Right? It just means everybody has, and different countries have different types of universal coverage and universal care systems. So some, Netherlands, for example, and they're on a comparison group here, they have a system where it's everybody pays into the system, and the government is the payor, so it pays, but the entire healthcare system is privatized, so it's private. And so there is some systems like that. In the UK, pretty much the entire system is both paid for and delivered by the state, the government. So different variations of, but the one uniting thing is that everybody is covered. Everybody is covered. What happens here? We have many coverage things, right? Everybody is with me? All right. And is everybody covered? No, I showed it to you on the last slide. So not everybody is covered to begin with. Then there's variations in the coverage. And if you do not have the right coverage for you, you may not gain access. And we've seen the access problems and all of that, right? So despite insurance system being here, it is very fragmented. Not everybody has access when they need to whatever they need, right? Like that's a big thing. And so obviously higher income populations here are doing better than lower income populations, but everybody experiences those problems. And how does our insurance work, right? Do we have a state insurance? Yes. So we have both federal and state insurance systems that covers whom? So like there's a coverage for low-income populations on the state side. The federal system, whom does it cover? Like older people. Yeah, okay. So now just take off that, forget about that for a second. How does your car insurance work? Does any car insurance company come around and say, I will only enroll you if you absolutely will have an accident? Yeah, no. Nobody does that. Nobody will survive with that. Because there's such idea as risk pooling, right? Like you have to enroll sort of very diverse swath of probabilities of getting into an accident, into insurance, for it to work. Yeah, now back to Medicare system. Yeah, it's like, woo, we have universal coverage for those who absolutely will use it. Now, and that system, guess what? Can't sustain itself because there's nobody else who maybe will not use it but is paying into it. And this is the biggest difference there. Too, with Medicaid as well, low-income populations, more probability because of other, social, environmental factors and all of that, more probability to seek care, right? And use the system that so less wealth. And so we do have it. We parade against it and whatever. We do have it. It just doesn't cover everybody, and that's why it's so lopsided, and that's why we're not getting good outcomes of there. So something, something to think about. And I'll show you this before we go on break. This is who pays for healthcare, and I promise you we'll come to that number again. Remember that thing of out-of-pocket thing that we're like, oh, this is the out-of-pocket. That's households, like all of us, just dishing out money out of our pocket. Includes our deductibles, copays, like stuff that we pay directly to healthcare. Then private insurance combined, right? That's what insurance pays. Now, do you pay for insurance? Okay, so you got to carve out that and add it into that. Like if you really want to understand what you pay, and then who pays for that? We do. Through taxation. We already, as individuals and households, pay the most into the system. We already pay it. And yet, we're not demanding access for it. We have paid it. It's not that if Universal will come and all these scary messages around it, like, oh my God, you're going to pay so much more. No, you won't. You're already paying it. You just don't see it. It's not in your face. And so the difference between our system and Mexican, so like that system, and everybody else's, is that everybody pays and everybody has access. With us, we're like, if we're younger, we're like, why should I bother? Why should I pay? I'm fine. Like, all be all good. Okay, so be it as it may. Imagine when you're old and there's no money to care for you, and the young people are like, screw you. I'm okay. I'm fine. I don't want to pay. If you're lucky, you all will get old and will seek care. And stop just hoping and praying and wishing that it will be available to you when you need it. Start doing stuff about it. And we're going to talk about all of the stuff that you can do, review a little bit more about this after the break. I'll let you out for a whole 15 minutes. So be back when the big hand is on, 9:58 Pacific time. All right. Welcome back, everybody. Hope you had a good break. Hope we didn't lose too many people out in the cyberspace. We're going to start with you out there in the cyberspace. And I'm going to pause a bit. And we're going to ask Mary to see, if you guys have any comments, questions, or anything on what we've done. Ooh, look at this. What's happening?
She's going up and doing it.
What is happening? Okay. While we're getting that going. So if you have questions, comments, anything on what we've discussed so far, any other insights, please throw them in the chat, and then Mary will tell me if there's anything. Loading. I love things loading. Yeah, no. Do we really even need that? I don't think so. No. Yeah. Okay. All right. Okay. It's like, no, computer. Okay. Anything so far?
A lot of people are just saying no questions at the moment, saying hi and that they're still here.
Hi. Good to have you still here. Okay. So in this next hour, I'm going to show you a couple of other data points. But what I really want you guys to start thinking about, and we've spoken and talked about a few things of why these outcomes are the way they are. But we'll dig deeper into that of why we're experiencing what we're experiencing, both the high level of spend and low level of access, and really undesirable across the board health outcomes. And so start thinking about that. It's kind of why, right? We've, again, called out a few things, right? Anyway, I'll pause on that. Maybe you'll recall. And then also for each one of those, as you speak about that, either yourself or somebody else can chime in, of what it is that you could be doing as a nurse, or right now as a nursing student, to start changing some of those things. And so right now, and then in the future. And as you think about that, and you're talking about those things, I also would like you to get some, not just sort of like, it's nice words, and I think I'm going to do this. But start making some commitments to yourself, right? This is what I can do. This is what I will do. This is, I'm on a path, and maybe I'll give you some ideas as well as we go through it and talk about it some more. So this is the who pays, so the payor. Obviously, very fragmented, very disconnected. Insurance is broken type of system. Let's see if that. Sophie to the rescue. Sophie. Anybody? No, it's not clicking. Uh-oh, I know. Like computers and me, no. Tubes that go in orifices, yes.
It won't go.
Okay. Oh, now it went. Present from current slide. Yep. Okay, awesome. We're back. Yay. All right. Okay, so this is the sponsorship of healthcare, right? And again, the sponsor thing that we've talked through. So households, right off the top, premiums, all of that other stuff, 28%. Private business pays 18%. Households, 28%. But also remember that other is like charitable foundations, things like that. State and local governments and federal government together is the most. But all of that is not any kind of magic money. It is the money that comes from taxpayers. And so if you look at that, about 24% of it comes from sources that are not you as an individual. Everything else is you and your family, and we all pay. And again, and I would like you to, think long and hard of how we're gonna change that, and why that is, and we're going to talk about the reasons why the spending is so high in a second. This is where the money goes. Hospital care, $1.7 trillion in 2024. That grew by 9.2% from 23 to 24. Did our economy grew by 9.2% between 23 and 24? If it did, we'll be like, wow, the envy of the globe. It didn't. Healthcare did. So $1.7 trillion. Why? Why hospital care is so expensive? What do we do in hospitals nowadays? Well, we do everything. What do we treat there? Why is it so expensive? What ends up in the hospitals? Emergencies, yes. But what else? What is the most of what we do in a hospital? The what? No, not in terms of what in terms of taking care of what? Maybe.
Charge the patients too soon, and the patients end up.
Maybe. Okay. So there's all sorts of like premature discharge, and then somebody's back in the hospital. But who ends up the most in a hospital nowadays? Okay. When the hospital system was created back in the elderly, okay, we're getting closer, but why elderly? What type? What type of elements? Deathly elements? Sure. What type of? Well, maybe not, right? Maybe they will recover, maybe not. But why older people more than younger? They're more susceptible for, like, there's susceptibility, there's all sorts of things, but also with age comes what? More chronic conditions, and we treat exacerbated chronic conditions mostly in the hospitals. So we are very, very bad. We're doing it poorly in the system. Managing chronic conditions is very poor. We don't manage them well. And so they exacerbate and exacerbate and exacerbate, and then they end up in acute care when it's the vast majority of it could have been prevented if managed well. And now they're on the brink of death with whatever it may be, and it is very difficult to treat and very expensive at that point. Shifting that care forward into the primary care system that is very, very poor in the country. You saw our primary care providers compared to everybody else's. What they do in other countries is that they work on preventing something from happening so it doesn't end up in acute care and cost an arm and a leg. We don't do that. Our primary care system leaves a lot to be desired. Because, ICU is sexy, right? Hey, you all want to work there. No, that's not where we need you. You're working with communities, populations, keeping them out of there. I was like, but that's not sexy. But it's needed. So think about that, right? Like as you sort of ponder your career trajectory, career choices, and all of that, and your impact that you can have, right? You can have a much higher impact on many more lives in your communities if you shift, a bit more upstream from acute. So physician and clinical services, $1.1 trillion. Almost $500 billion on. That's a lot of money. Like, by the way, are you computing the zeros in these numbers? Like, because, trillion, and you're like, oh, yeah, okay, whatever that means. Okay, so 100,000, right? Like, it's like, if you were making $100,000, you would not be sitting here. Everybody with me? Yes. I was like, if I found that job, okay, so let's get that out of the way. And so it feels like a lot of money, right? Then you add a 0 to that, right? You multiply that by 10. What do we get to? $1 million. No, just 1 million. When you multiply 100,000 by, like, you get to $1 million. Wow! If you have $1 million at retirement, probably okay. I mean, depending on inflation, right? It may not buy you much, but like for now. Then you multiply that by 10, that's 10 million. Like, whoa, you're rich. Like, legitimately rich. Yeah? Multiply that by 10, you know, you get to 100 million, and it's like, whoa, unheard of. And that's only, you know, 1 and 2 zeros and 3 zeros and another 3 zeros. Yeah, 100 million. Now you multiply that by 1,000 and multiply it by 1,000 again, you get to 1 trillion. That's a lot of zeros. Like do an exercise for me, like one of these days, like when you have nothing else to do and there's nothing to scroll for anymore. You like write on a paper like 1 and then start adding zeros until you get to that trillion number, and it is mind-boggling. Then you multiply that by 5.3, that's how much we spend in healthcare just in 1 year, 2024, and these trillions, or you know, $500 billion on prescription drugs, and we've talked about prescription drugs, right? Like we use the most of the entire world per capita. We pop them puppies like, so good. So tasty too, just like candy. Remember Lucy? Probably not, you're too young. Health, residential personal care, much less. This is, you know, this is long-term care, stuff like home things. Nursing care facilities actually here at 230 billion, dental services at 189, and so on and so forth. So that's the number. If you want to make real change, this needs to go down, the acute care spend. And the only way to break that is, again, is to shift care away. And not that like you shouldn't have care, but preventative services, effective management of chronic diseases, health promotion, you know, perhaps advocating for now, you know. It's like Game of Thrones, right? It's like, I'm a dragon. And it's Peach. Sexy. Probably not good for you, but you know. Oh, kids. All right. So that. Oh, I love this one. This is an older study. I'm sure I've tried estimating what it would be in 2023 based on the same proportions from the 2019 JOMA study, the Journal of, or JAMA, really. Administrative complexity, what is that? Why is that? Waste. $286 billion back in 2019.
So what falls under that category? Is that like training staff that
No. Administrative complexity of the healthcare system. What's complex about it?
the navigation.
Navigating it, yes, but on the administering it side. What is healthcare system? Maybe we should have started with that. It's the collection of all of the providers and the collection of all of the payors. Right? That is the system. Providers and payors. Okay. Why there is almost 300 billion, and probably nowadays more, wasted.
When you say payers, you mean residents and insurance, or what are
Yeah, insurance, you know, the government, the whoever pays, right, in the system. So somebody provides service, somebody pays for the service, right? That's the system. Why administrative complexity and waste compared to other countries? They don't have that. Come on. Multiple disconnected providers and multiple disconnected payors. And imagine where each payor, and depending on their size, whatever it is, must negotiate and set rates with every single system that exists, little hospital, big hospital, that place, whatever. That is money. That's when, we should have done something. Yes. Questions?
Should we pause?
Yes. Okay. Did we lose them? Cyberspace vanished. We're good? Okay. Cyberspace is back. Whew. All right. Failure of care delivery. This is when somebody in the system already and they get discharged prematurely, for example. That's a failure of care delivery. Because if we would have kept them and got them to where they were actually dischargeable, they would have not been back and we would have not spent that. And that's just one of the examples of the failure in care delivery system. Fraud and abuse. A lot of that happening. You probably see the news and every once in a while something pops up. Pricing failure. What does that mean? Failure in pricing.
Overpricing medication and procedures.
Right, but why failure? Why a waste?
A lot of it probably has to be written off in some cases, but various discrepancies.
Yeah, not necessarily discrepancies. So go ahead.
Possibly charging them for the full dose of medication and not giving them the dose?
Not necessarily, no.
Doing too many unnecessary tests.
Okay, so overtreatment, all low value care, that's there. Unnecessary tests, perhaps they not like doing the full, it's in this. Pricing failure, again, stems from the system itself. You remember me, I just said it a few minutes ago, where multiple payors set prices with multiple providers. And they're different pricing, and every provider has their own price. And all of that stuff happening. Now, imagine if that would be happening, you as a shopper, right? Amazon, right? You want something, you need something, and you're like, ooh, from this seller, it's 3 cents less. I'm buying that. This is the same thing, but I'm gonna buy it from them because I don't have to offer ship or whatever. I don't have to pay as much, right? You're not like the first whatever. It's like, Google, bring me this, and you're like, yep, paying $100 for this, where you could pay $5. None of us do that, right? We don't just in healthcare. We constantly do it because of how our insurance system is set up, and you perhaps if you are covered, see only $25 copay for something. You don't care where you go. Because to you, it's the same. Where it's not the same is the system. Because the same procedure, the same test, I had some years ago, I was experiencing some shoulder problems, and I needed an MRI under an X-ray with injecting a contrast. And I actually shopped around for it. And one provider where I was referred to was close to $3,000. Another provider where I actually got it was under $500. The same thing, same quality, or maybe better. I don't know. Same procedure, way different pricing. And so that's that. And failure of care coordination. That's that disconnected provider system where one provider doesn't talk to another provider, and then if you're like, oh, what's wrong with me? I already have been to a cardiologist and pulmonologist and whatever ist that you can. I've gone to them all. Nobody knows what it is. None of them know also that you've gone to them all. And so there's no coordination of any kind of information or data or anything that one obtains maybe that can be combined with the other. Then the puzzle is solved. Nope. That billions and billions and billions in waste. Okay, so to summarize, I'm drum roll. This is macro level, so big, large system factors of why healthcare system in the United States does so poorly, relatively poorly. Obviously, if we were hey, we should be comparing ourselves to I don't know, some countries in Eastern Africa or Central Africa. I was like, I mean, for sure winning. I mean, we're doing so good. You know how much those countries spent? Near zero. So not a good comparison group. Yes, we're doing better than them, but not a fair comparison group. So weak primary care infrastructure. Who is in primary care? Who works in primary care? Physicians and nurse practitioners. How many of you are going on after you're done with this to nurse practitioner? Very good. Good for you. Yes. You guys too? Awesome. Fantastic. So nurse practitioners are needed. By the way, there's studies that suggest that we're way more effective. I'm not a nurse practitioner, but we're the nurse. We're way more effective in all of that stuff, that the avoiding waste and coordinating care and listening and doing all of that. We have more time. We're not compensated as much. We should be compensated more, but not as much as physicians, and therefore it is more cost effective in the communities and so forth. And we get to better outcomes just with the sheer fact that we spend time with them. We listen to them, we care compassionately for them. And so those of you, good on you, go continue. This is one of those solutions that you can drive personally. Now, in order to get to be a good primary care provider, you need a lot of knowledge, a lot of skill, a lot of reasoning. So again, back to this, what can you do now? If you're gonna be a nurse practitioner later, get more than 72.5. I'm just saying. No, I'm not just saying, I'm demanding. Sometimes that will mean that you will have to hang up, tick tock, tick tock, tick tock, you know. And certainly you don't have time to be a TikTok star at this point, at this point in your career. Later, when you're like Cool NP, and you can also record videos or something. I don't know how it works. I literally, people show me a few things, but I haven't seen it. Otherwise, so that. Anything else in the weak primary structure that you can do? So, think hard. Who makes decisions about healthcare system? The government does. Yes, the government does. Yeah, So what can you do? Replace the government. Okay. All for it. I vote yes. Replace with whom? Who? People in healthcare. Okay, we're getting there. Yeah. Do you know how many nurses serve in U.S. Congress? 2. 2. Do you know how many people total are in the U.S. Congress? 450 some in the House, right? 100 senators. So 0 senators are nurses. You know how we said that for every 100 people in the United States, 1 is an RN? The 100 people that are in Congress, or not in Congress, in Senate, none of them are an RN. 0. Do you think all of this stuff is understood, talked about, and all of that? No, because there's nobody to drive that conversation. There's a couple of ducks, but different. It's different. What we do is different. So what could you do? Who? What's your name? What's your name? What's your name? Amira. Amira for Congress. Yay. Right? There you go. I know. You got to know your stuff, though, right? Right. Not 72.5, exactly. You have to know your stuff. You have to be credible. You have to show up with credibility, not with, again, if you continue paraphrasing and talking and repeating, most of which is just nonsensical stuff. From the entertainment shows like MSNBC, CNN, whatever, and Fox News or whatever, like pick your poison. Those are money-making machines. They're designed for entertainment. And people buy entertainment. But it's not, most of those sources are not credible. And pundits and talking heads and whatever you heard, discard it all, find evidence. Actual evidence. Not sort of like, Claude made it up. Although that one is okay. AI still hallucinates, so you may get an answer that is still not correct. Because they so want to please you. And say something, Yes. Not good. Actual evidence. Where do you find evidence? Where do you find evidence? I showed you tons of it today. Credible sources. What's one of the credible sources that you learned about today? It's called the Commonwealth Fund. The Commonwealth Fund. You can find data, health data, down to county level. They're amazing, all of the research that they do, and the outcomes that they show you, and all of this. You can find stuff there. Credible sources like OECD, Organization for Economic, like if you want to look globally, compare, do all of that. Journals, yeah.
You said Commonwealth what?
Commonwealth Fund. It's commonwealthfund.org. That's where you find that. You have journals, peer-reviewed journals, where studies are published, although there's a little bit of kind of this wave going through that community now where people, some use AI to help them write it, and then an AI, as we know, makes stuff up, and then so even more careful we have to be now, like with all of those sources, but at least there's some sort of like a lot of peer review. Some of it doesn't, like is caught and doesn't get through. But better than a an online, some obscure website still is more credible. So evidence, you need evidence in order to change anything, in order to speak about anything, in order to push others, right, and convince others. Whatever office that you may run for, local level, whatever it may be, if that's in your future, again, know your stuff and know the evidence. And then you can position yourself well to drive that change in the community. Everybody, like pretty much all of you said, yes, I'm here because I want that, right? Like I mean, obviously you all want Prada shoes, I get it. Better pay comes with being a nurse, and it will change your life, your family life forever. That it's all true. That is true. But if you're only in this profession for that, it is. You will be part of that 50 and 33% statistic. So find something else. Find something that, make a commitment to your community. Small circle, all your Facebook friends. I'm going to be responsible for your health, people, from here on out. Do like me. All right, so that high out-of-pocket cost, we've discussed a lot about that, and complex insurance system. So, and that again, that is not going to change until the highest levels of government wake up, smell the evidence that exists and has existed for a very long time, and say enough is enough. We need to do something different in order to get. Otherwise, it's all talk. And nothing changes. It's all wishes and all of that. Okay, this is factors affecting poor health outcomes. We've talked about some of them. let's dig in a little further. So systemic inequities, generational poverty, we've discussed that. Low-income populations obviously get worse health outcomes than higher-income populations because of all of this systemic stuff that's built in kind of decade after decade, generation after generation, and so on. So any of you, you don't have to be like, oh, it's me, but like if any of you, let me phrase it this way, if any of you grew up in intergenerational poverty, you really know what it feels like and how, what it feels like. And you committing to be better than this just mere 72.5%, and knowing your stuff and driving forward, persevering through this, when you get to work as a nurse and you get that paycheck, you have broken generations of inequity for you and those to come after you. This decision that you made is big. Becoming a nurse is big. For you, yours, all of that, but for many, many more beyond that. So I came to this country as a refugee, and I understand firsthand what it feels like. Nursing for me became not just sort of a way out, which is it provided the way out and more and more and more. It became fundamental passion of mine because I know what it did for me, and then I know what it can do for others. I know what it can do for communities. We are, again, if only every single one of you commits to that. The better future than I've shown you on the slides. The slides describe now, describe the past. It doesn't mean they need to describe the future of it. So that, social isolation and loneliness. And if I can, whoa, I did something. Oh no, okay. I will do my best to try to pulling it up. Thought I had it all laid out, and I don't. I had some interesting, hold on, give me a sec. I'm gonna find it. My computer is not cooperating, or this thing. I'll read you a couple of tidbits on that particular. I promised you the California obesity rate, 37.6, so under the average. Yay, good for you. All right. These are the studies that have been done over the past decade or so. Lacking connection can increase the risk of premature death to levels comparable to smoking daily. That's that social isolation. Living in isolation reduces our chances of survival, and social isolation increases the risk for premature mortality by 29%. Poor social relation. Now, TikTok is not social relationships. Everybody understands? Okay. It's sort of this environment, 3D. Meet each other. I know a bunch of people know each other in this room. If you don't know anybody, make sure you meet somebody before you leave, because it'll be easier. And I know there's probably a mix and mingle or something like that later. Are you guys doing that here? Mixing? No, you're not doing that? Well, mix amongst yourselves after we're done. So smaller social network sizes associated with an increased risk of type 2 diabetes and other diabetic complications, including heart attacks and kidney disease. Among older adults, chronic loneliness and social isolation can increase the risk of developing dementia by approximately 50%. If somebody's lonely, one out of two will end up with dementia. Being more socially connected, on the other hand, can improve stress responses, minimize negative health effects of stress. social isolation, or even the perception of isolation. Many young people suffer of that because of, on social media. Can increase inflammation in the body to the same degree as physical inactivity. You can be active and lonely and not good. Loneliness and poor social support have been found to significantly contribute to the development and severity of illnesses after exposure to viruses. COVID, remember? Remember which populations were suffering the most? Has to do with that. So, climate change. Is that a health issue? Why? How? The what? Environmental, right, but like what? Pollution, right? So pollution is perhaps it's an environmental factor. It's contributing to the climate change, but it's not like so something like asthma and prevalence. I live on the Wasatch Front, so in Salt Lake City in Utah, and the prevalence of childhood asthma in that part of the country, right where we live in the valley, is the highest in the United States. Because many days during the year, especially during the winter, when the atmospheric pressure, I don't understand how it works, whatever, holds all of the pollution, all of the smog to the, in LA, it's kind of look okay here now, but it holds it down to the valley floor, and people breathe it, and kids constantly exposed to it, and so the development of these conditions is. So environmental factors are absolutely important, but climate change. What is climate change? What is happening with the climate?
Global warming.
It's warming up. The planet is warming up. The planet is melting. Icebergs and glaciers and all of that. More water goes into the oceans. You see it over and over and over again. It's not, it's not a joke. It is happening. It's happening slowly, but it is happening. And eventually, when the water levels rise, there's going to be less space for people to live in, right? So people will be migrating more and more and more toward centers, leaving islands, doing all of that stuff. When there is a higher density of population, what happens? Communicable diseases go up because we're in closer proximity to each other, right? And that is just one of the examples. As the planet is warming up, it's becoming impossible to grow food in many places, including in some places in this country. When it's impossible to grow food, what happens? Scarcity, all of that, the nutritional health goes down, wellness goes down, all of that. Climate change is a health issue, is a nursing issue. What are we going to do about it? Move. That one is global. It is happening literally everywhere. And so there are things we can do, but think about that. Think about that. Again, changing policy, changing public policy around things will help. But we need people who are willing to, do the work to do it in the places where the change can be done and can be driven from. Gun violence. Are guns a health issue in this country? Absolutely. So all of these arguments around should we have them, should we not have them, people with mental illness probably shouldn't. Do you know that for all of the mass shootings and other shootings and crime and everything else that you hear about, that is a fraction of gun deaths in this country? What's the largest proportion? Suicide. Suicide by a firearm. You already saw the level of suicides that we have in the country. When firearms are readily available, people do. People walk in their local mart, buy it, and they're lonely, and they're at the end of their rope, and rather than seeking help, which they cannot get, and all of that, they buy it, they take it, they buy a couple of bullets, they walk out and shoot themselves. It's a health issue, yes, and then injuries and all of the other stuff that's happening. Now, again, shouldn't be a political issue. For you as nurses, or for us as nurses, it should be a health issue. We should care about it because it does affect health, wellness, longevity, all of that other stuff. So yeah, part of it, again, in the public policy, part of it in creating environments and wellness and promoting health and doing all of that, all of the stuff in the communities that I've been talking about. The system has been built, we talked about that, after World War II to treat acute care problems mostly. After World War II, what was the biggest acute care problem? Anybody? What were we doing a lot in the hospitals? Smoking, yes. I mean, we were smoking a lot, but that leads to chronic conditions and all of this. Acute care. Accidents, right? So this is like early 1950s, late 40s. Accidents, yeah. So like accidental stuff was like, OSHA didn't exist. So it was like, oops. So there's like less safety standards and so yeah, accidents and things like that. But what was like the biggest acute care problem after the war? No. Babies. Babies was the problem. That is very acute. They come and then that's it. It's very episodic. So we build these institutions a lot to deliver babies and do some other stuff as well. And as we said today, because of how the system is designed, the vast majority of what we do there is treat preventable exacerbations that are very expensive, right? I mean, we still do babies there, but most of it didn't grow around the babies because the boom, that was a big one. Inability to access care, we talked about shortages, talked about the cost, our population health, the dragon breath and whatever else, we're sedentary, right? Scroll. Look at your finger, probably like this now. Yeah? It's like exercise your finger in different ways. Preventable, poorly managed chronic conditions, and disengaged financial sponsors. So the system keeps increasing and increasing and increasing its costs, and we keep paying and paying and paying and paying, and most employers without asking any questions, or without asking for something else, something different, some other programs that may create wellness among their workforce. At Nightingale, by the way, we do have, we call the program, we have it, we call it Wellevate, and for getting healthier, we actually pay people real hard cash. It's like, here you go. They collect points and do it's a whole good sort of thing, but does your employer do that? Or they just pay and pay and pay and pay, and you're not getting any healthier or weller. So think about that and things that you can drive, right? You can go to your HR departments, especially if you're like in a small institution, and say, hey, should we try something different? Rather than constantly dumping, money into the endless pit. Think about that. High spending, unnecessary care. Talked about that, right? The system pays for services, not for performance. So it's like, we prescribe this and do that and whatever, no matter whether it will result in a good outcome or not. Pay and pay and pay and pay. Overprescribing, talked about that. Unnecessary diagnostics, that lack of care coordination, where I have gone to this ist and that ist and that ist and that ist and that, and everybody's prescribed like this test and that test and whatever test and whatever, like whatever, and it was really flu or something. I don't know. Stress, right? Lack of connection, whatever. So lack of care coordination, we're litigious, so there's not a lot, provider shortages, not a lot of time spent. We lack focus completely on promoting health, preventing disease, and managing chronic conditions. I keep repeating this one thing, and hopefully it's sticking in your head. Health promotion, disease prevention, effective chronic conditions management. Because you all, without you, ain't gonna, not gonna, like, unless you start focusing on that, not gonna change. Look at that one in consumers. You know those scary pictures on cigarette packs? They're like, nah, they're not gonna happen to me. Yeah. We're so optimistic. Oh, I can continue doing this, and it's gonna be just fine. Dr. Deming in the 1950s said that every system, including you as a person, that's my addition to his saying, is perfectly designed to produce exactly the outcome that it is producing. Meaning any outcome that you experience in anything, systemically, individually, with your study, or with whatever else, is the product of the system that you've built. All of the little pieces or big pieces, whatever, that go into it. And unless you change that system, like stop scrolling, for example, that may be a change for some of you. And like, hopefully some of you heard me and it's like, oh yeah, this is really bad for me. And like, I think I'm addicted. Can somebody help me? Real thing. Social media addiction is a real diagnosed thing now. Can be treated, but you got to put away that phone. Ladies, put away the phone. We're so addicted, we don't even notice it. We don't know. Addicts do not know they're addicted. Stop being addicted. This one is not that difficult. You don't have a physical addiction to it. You can put it away. It's not like cigarettes or alcohol or drugs or anything else, which has to be treated. This.
Even our children.
Oh, your children is even more addicted than you. So separate, right? Separate yourselves from that stuff. Focus on stuff, on getting more than 72.5, because that allows more, that requires more time. I'll be harping on that because inevitably some of you will email me, text me. So, no, you won't text me because you don't know my number, hopefully. But you know my email, and everyone, every semester, I get this change my grade. I deserve more. I really tried. I'm like, First of all, I don't have such power. Your faculty is the only people, I want you to hear this one really loud and clear. Not Dr. Olson, who's the college president, not Dr. Johnson, who's the provost. Those are administrative positions. Can change your grade. Faculty, who, but stop chasing the grade also. The grade should be an outcome, a side effect of what? Learning, knowing, doing, all of that. Focus on that as the goal, on learning stuff, on knowing stuff, on having enough stuff under your belt to change all of that stuff that we talk about. And then the grade will kind of just that you really, really want will follow. Not the other way around. Can't chase the grade. So, a lot of things you can do. Okay, in the last few minutes. Uh-oh. Oh! Well, it's final thoughts. So, what I'd like to hear from you in this 10 minutes that we have is, what are you going to do? What are you committing to? What are you going to change? What are you going to chase? What are you going? Run for Congress. Amira, was it? Yeah, okay. Fantastic. Hey, yes. Yeah. Fantastic. I mean, and look, that's not a joke, right? Another thing, like if you want to get involved, I mean, there's like county health boards. There's like all sorts of stuff you can or ways you can involve in public policy, but also get involved in like the system policy, right? Because within the system, there are very few nurses that serve on hospital boards, for example. Very few. And yet hospitals are what? Mostly? They're nursing services organizations. And yet we do not govern them. Have I mentioned we're complacent? Yeah, I'd like you not to be and commit to that. You don't need to do it all. Just pick something and stick with it and go for it. Become passionate about it. Know everything there is to know about it. Drive it forward. If you see an inequity somewhere, it is yours to change. Like, well, I can't. I'm just one, the only little tiny whatever. I mean, this, refugee that came in the country with like nothing. Figured it out. Although I still talk funny. So, figure it out. You're not powerless. You can do stuff. You can change stuff. You just have to become very, very passionate about it. All right. What else? Others. What are you going to do? Yes?
For example, I want to become a nurse administrator.
Okay.
Do the operational leadership part.
Nice. I'm like, you and me are on the same page. Oh, yeah. Passion. I went for my MBA instead of, nursing masters. I was like,
And I have a master's in healthcare administration.
that's awesome already. Yeah. Wow. Combine this with that. Unstoppable. Very good. Awesome. Thanks for coming and doing this. This, who else? Who else? Come on. What are you going to do? Who's going to hang up the phone? All raise your hand. Yeah. Or physically separate from your phone. At least more than the time that you're sleeping. Okay, good. Somebody's with me. Good. It is good for you. You're going to feel better. I promise you. That thing, I'm like, whatever. If you're watching Netflix, stop scrolling at the same time. Because you're neither here nor there fully. It's been absolutely conclusively proven about our brains. We cannot focus on two things at the same time effectively. Period. It is science. Yes, please. Yeah, because you were raising your hand. Yep. Exactly. So, yeah, a bunch of you have kids, right? Yeah. Setting an example for them, for others, somebody else, your siblings in your family or whatever, doing this and persevering and resiliently going after it. And it doesn't come easy, and it doesn't come on a first attempt all the time. It doesn't, but it comes if you keep pushing to it and putting the work and doing all of that. So that's, but also work on removing systemic barriers, specifically to education. This state and its Board of Nursing is notorious for creating barriers to your education. For one reason or another, they don't want more nurses here. For one reason or another, they really don't care about diversifying the nursing workforce here. All they care about is control. So I cannot change it. I do not live here. You can. You have to start talking to your legislators, not just us, who come as an outsider and say, hey, these people should be able to do their clinical rotations in this state. Change the law. Guess who blocks it? We tried several times. The RN board and the nursing union. So start doing something about it, right? And this is just one example. You have to dig and dig and dig, identify these barriers, identify the policy, identify everything that's holding you individually or your family or your community or your state back, and push back. And status quo is powerful. It's going to be pushing against you all the time. But if you persevere and you resiliently, you go for it and go for it and go for it until that barrier falls. And it will. But it will not do it of its own free will. It must be forced to crumble. So, look, I do these every semester, these talks, and I look at I go around the country, and I see, meet amazing people like all of you, and with all of your, passion and curiosity and everything else, and desire to change your life, desire to change and help in the lives of others. And every time I show up, like this, it's very fulfilling, and also gives me a lot of, I'm gonna say this, it gives me a lot of hope. I don't just hope, I do stuff. I build this because it's my thing to do, right? And that's the stuff that I decided to do, to open up these opportunities and doing all of that. You all can and do a lot. And so the hope that I have is that you carry out resolve out of this, some evidence, some resolve, some passion, some trajectory for now, for your career as a student and as a learner here, and your further career as a nurse. And then that one of these days, we get together at some point, and we're looking at very different picture on the screen. We're looking at a country that is actually healthier and actually more united. Because, this truly, I'll leave you with this because I don't have an opportunity to, another opportunity to talk to a bunch of learners until then, but this country, with everything that ails us, it still is the best nation on earth, with the best people who can do stuff and change stuff, and who can find common language, and we can agree on things if only we started coming together, listening to each other, and individually driving stuff forward. So thank you. I think the future of nursing is bright, because I look at your faces, and your faces are bright, and again, and I'm so excited about it. I love what I do, and I hopefully, for all of you, that's going to be the case as well. So thank you so much. I appreciate you, and safe driving back. Thank you, people in cyberspace.